It was terrifying. I really thought I was going to lose my practice.
The data is sparse, but national surveys show high burnout and precarious finances among primary care doctors.
I think you're going to see some real holes develop across the nation where access becomes very difficult.
Are there ways that you can meet your patients' needs without having them come in physically to the clinic? That may mean that we're asking some of our patients to change from an in-person visit to a video visit.
We've been converting a lot of our patients to telehealth visits. We're working with limited staff, trying to keep ourselves healthy as well as the rest of the public. We're trying to keep everybody out of the emergency room, keep people calm, trying to educate them. We know you, we have your medical records, we know what medications that you're on. If you go to the emergency room, they don't know you.
Primary care offices are historically where the largest share of vaccinations are given. The majority of patients during the COVID-19 pandemic were still dependent on their primary care offices in order to get information about the vaccine.
I tell them that my job as a primary care provider is to keep people from, having to go to the emergency room. They trust us. And that's the power of primary care, right? That's continuity of care, some of the magic that's necessary that we don't often see. We provide care not only for COVID, but for everything else. High blood pressure, diabetes, heart disease, kidney disease, asthma, COPD.
As we rebuild our healthcare systems and our economy and our communities now, we need to ensure that we do better. And that means that we need to approach this opportunity to build in equity by design.
The last year has shown us that we are able and capable of moving. What is super exciting right now is I think the National Academy's report that came out several weeks ago should help create some activation energy and lower that barrier for us to be able to sustain some of these changes that we've had to do out of necessity. What we all signed up to do in a weird way was really what we've been doing this last year, which is to be innovative and to do things in exciting ways to meet people's needs. And I don't want that to stop.
Hi, everyone. My name is Sarah Hager, and I'm the Director of Prime Registry, Primary Care's only qualified clinical data registry. We are part of the American Board of Family Medicine's Foundation through the Center for Professionalism and Value in Healthcare. I'd like to thank the attendees for joining us here today, and as well as point out a quick overview on PCC for those who aren't familiar. PCC is a nonprofit multi-stakeholder organization that unifies and engages diverse stakeholders in healthcare, promotes policies and shares best practices to support growth of high-performing primary care. Membership organization, 60 organizations committed to mission and additional supporters, dedicated to advancing an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. A couple of housekeeping reminders. All lines are automatically muted, so please submit questions in the questions box, and we'll get to those later after the panelists have had a chance to share information. Questions from the audience will be addressed after a panel discussion, but feel free to send in questions at any time. The webinar is being recorded. Recording plus any slides will be posted within 24 hours. Just the layout of this webinar is that technology is in every part of our lives these days, including healthcare, and it has probably been more part of our lives during the pandemic due to this spike in telehealth. Today we'll be talking about what's working to uphold the promise of advanced primary care captured in the shared principles of primary care. We'll consider how technology might be undermining such promise, how it's enhancing the quadruple aim, and where may it be getting in the way. Of course, we also have to consider equity as a factor in use of technology and how our use of tech can advance or harm our efforts on closing healthcare equity gaps. And we'll talk about how better use of technology could have helped primary care and public health during the pandemic. And to do all that, we have gathered a great panel of experts, thinkers, practitioners of healthcare technology and information. With that, I'd like to introduce Dr. Anil Jain. He is Chief Innovation Officer at Innovaccer. Previously, he was VP and Chief Health Informatics Officer at IBM Watson Health. He was co-founder, Senior VP, and Chief Medical Officer of Explores, formed in 2009 based on innovations that he developed while at the Cleveland Clinic. In April 2015, Explores was acquired by IBM as an integral component of the newly formed Watson Health Business Unit. In 2017, he was appointed by Congress to the Federal Health IT Advisory Committee established by the 21st Century Cures Act. He obtained a biomedical engineering degree and medical degree from Northwestern University, trained at the Cleveland Clinic, and subsequently joined the Department of Internal Medicine in 1998. He has authored more than 100 publications and abstracts and has delivered numerous talks on health IT innovation through applied clinical informatics, interoperability, big data analytics, and cognitive computing, artificial intelligence. We also have the pleasure of having Dr. Charles DeShazer. Charles is the Director of Clinical Products for Google Health, where he helps lead the design and implementation of an intelligent suite of tools that help healthcare clinicians deliver better patient care. He previously was the Senior Vice President and Chief Medical Officer of Highmark Inc. from 2017 to 2021. Additionally, as the CMO for the primary division of Highmark Health, Dr. DeShazer also interacted regularly with the smaller health division Allegheny Health Network, as well as Penn State Health. Prior to joining Highmark, Dr. DeShazer served as the Chief Quality Officer for Bay Care Health Systems from 2012 to 2016. From 2010 to 2012, he served as Vice President, Medical Information, Quality and Transformation for Dean Health System. And we also have Dr. Elisa Choi. She is a practicing physician in Massachusetts and is the Chief of Internal Medicine Department of her practice. She is the governor of the Massachusetts chapter of the American College of Physicians, a PCC member. She is also the current chair-elect of the Board of Governors of ACP National and will step into the chair role next year. She has been involved in IT-related efforts in her practice. She has a particular interest in healthcare disparities and in providing culturally competent care of health issues affecting Asian Pacific Islander and minority populations. She has been on the faculty at Harvard Medical School for many years, in addition to being board certified in internal medicine. She is a specialist in infectious diseases, HIV, and hepatitis. I think everyone can agree that it's an amazing group of panelists that we have here today. We're going to hear briefly from each panelist, and then we'll come back together for a discussion. First up, we have Anil.
Thank you, Sarah, and thank you, PCC, for the opportunity to talk to all of you. So, when I think about advanced primary care and I think about the role of technology, one of the things that I like to do is see if I can explain it to some of our folks in our organization. I'm at Innovaccer, which is a population health platform company, really trying to use data and essentially deliver some of the insights that we all need in primary care, as well as other forms of the innovations that are happening in health. What I try to explain to them is that we really need for every single person in the primary care ecosystem to be operating at the top of their license so that we're delivering the highest quality outcomes to our patients in the most cost efficient manner. And for that, we really need to be thinking about several different aspects. I also try to explain, and I'll go through those in a second here. I also try to explain to them that electronic health records are necessary in this journey, but insufficient. There's a lot of essentially poo-pooing the idea of where EHRs are and where they got us to. But the way I look at it is they got us pretty far along the journey, and now we need things to sort of close some of those gaps, and I'll talk a little bit about that. We also need, and I talked to our junior folks about the need for stakeholders to align around what it is that we're trying to do around the value proposition. And then for everyone who's involved, whether it's the plans and our providers and our patients and those who are delivering technology, we need to have trust and transparency about what it is that we're doing, so that when we are reimbursing for the right types of care, that everyone actually agrees with what it is that we're measuring, how we're measuring it, and what the outcomes that matter that we're achieving. So let me talk a little bit more about these different areas that I ask our folks back at Innovaccer, and in my prior life at IBM, and in my prior life at Explorers, were cornerstones for what we were trying to do in the market. I think we would all agree, whether we practice medicine full-time, part-time, or not at all these days, that if you don't have the right information, it's tough to make the right decisions. So one of the most important things in thinking about technology and advanced primary care is how can we bring all those different disparate sources of information together and bring them in a way that we're creating a 360 view of the patient. We just happen to call that part in our solution stack, we call it Patient 360, but there's a form of that in various different solutions. Bringing together claims data, electronic health record data, and more importantly these days, bringing in some of the other sources of data, medical devices, thinking about some of the consumer level data, the social determinants of health like Aunt Bertha. How do we bring all that data together and create a 360 view of the patient, so that when we are making these decisions, that we are doing so with all the information that can possibly be gathered, working together. Now, lots of little subtleties about that we can get into later on in terms of latency for claims data versus the near real time for clinical, but the idea is that we need to bring all this data together. But then one might ask, well, wait a minute, how do we make sure that the data can all be it's apples and apples and not apples and oranges? Meaning, how do I know that when I say CP, I mean chest pain and not cerebral palsy? How do we get that semantic understanding of that data that's coming at us? And I think one would probably agree, and I certainly have seen advances in interoperability, but we're fairly far from having true automated, seamless semantic interoperability. There's quite a bit of work that needs to be done. And the question always comes up is, does everyone do the work over and over again, or do we find partners and platforms and solutions to help us do some of that low value work on making sure that the data coming in from disparate sources is able to be interpreted in very similar ways? Even things like making sure we know that Mr. Smith, who walked through the emergency room entrance last week, is the same Mr. Smith that was admitted to the hospital today, or that it's the same Mr. Smith that we're giving a follow-up appointment to next week. That enterprise-wide master patient index, and these days with clinically integrated networks and affiliates, really thinking through what does a community-based master patient index look like. And now with thinking through, well, wait a minute, if we're being responsible for a panel of consumers, some of these folks may not yet be patients. We may be accountable to them and keeping them healthy, but they may not have a patient ID. So really thinking through, what does it mean when we start thinking about identities of patients as we try to bring their data together, who may not yet even be patients. And of course, there are plenty of advances like FHIR and FHIR APIs that allow different systems to interoperate. But the bottom line is that if anyone says that we have achieved interoperability, I think they really haven't seen what it's really like when you're seeing patients and you're trying to string together various information systems. We're not there yet, but we made significant progress. Knowing where there are gaps and knowing where there are challenges help us do a much better job of interpreting that 360 view of the patient when we do have all that data together. Now, let's assume for a moment, in a perfect world, we are able to bring all the data together that we have available into a common data set and get us that 360 view. Well, what do we do with it now? The last thing a busy clinician needs is just more and more data being thrown at them. So we need analytic insights. We need either basic analysis that we would have done 10, 15 years ago to do basic block and tackle, or we might need more advanced analytics powered by machine learning or AI to deliver significant insights that might be elusive to a busy clinician. Things that we sort of take for granted these days. Some of these things can be natively built into electronic health records, but some of them that require data from multiple sources or require advanced processing might need to be done outside of the electronic health record. And thankfully, there's progress made, even at folks at our organization, where we're able to bring insights into the point of need and point of care without necessarily overtasking the electronic health record implementation teams. Things like Patient 360 and EndNote from our organization. And there's a significant number of insights that need to be delivered to these clinicians so that we are able to make the best decisions for their patients. An example might be having a dashboard of opportunities to help improve the life and welfare of that individual patient. So having technology that summarizes that data and makes it available on a dashboard is a critical piece. And then finally, and then we'll move on, is how do you deploy tools, and what tools do you actually need in order to engage with those patients and consumers who are now expecting a much different experience with their clinicians than they were 10 years ago. And then even so in the last two years or so, even significantly more virtual of an experience than they had ever experienced in the past. And then finally, just sort of to make sure that we all are reminded that technology is an enabler. We have to have the governance, the people, the processes down, and then technology comes in to enable. So really making sure we know what it is that we're trying to accomplish in a advanced primary care project to make sure that we're not putting the technology before the goals that we're trying to achieve. And we can get into some more details on these different areas, but it's really important to realize that if you don't have great data, you're not going to you're not going to get off on the right foot. If you don't have the analytic insights, all you're going to do is be giving information overload to the clinicians. And if you don't have a tight engagement and governance process, I don't think we're going to see the full value of what we can deliver in advanced primary care utilizing the technology we have today. Sarah, I'll hand it back to you.
Thank you so much. Next up, we have Charles. Charles, I'm not able to hear you. Is anyone else? Can everyone else hear him?
It's on mute.
That's okay. Thank you. Sorry I let you go too long. Thank you.
Yeah, I was saying that Anil covered the landscape extremely well. So I'm going to be brief and just highlight a couple of the points that he made, which I think are really, really important. But I want to start off by saying that I think that it's really critical to recognize that primary care is the key to the success of our entire health system. And if anyone read the National Academy report that came out earlier this year, they really laid out the case extremely well to really make that statement and to underscore how critical it is that primary care is successful in this country. And I think that leads to the second point, which is that there's too much demand on primary care today. It cannot be managed with the tools of years ago. It's absolutely impossible. So for primary care to be successful, and they talked about it in the report, it has to be tech enabled. And I think the opportunity that we have here is what Anil talked about, and I think we have to underscore the difference, which he alluded to, between digitizing electronic medical records and digital transformation. And I think that's where we need to go now. We really need to push into that environment where we have true digital transformation, meaning we change the interaction models between people, processes, and technology, and really leverage the capabilities that we now have that didn't exist even 10 years ago. Every person carries in their pocket the computing power of the computer that put folks on the moon in the 60s. Big data computing power is incredibly advanced. And obviously that is what has enabled machine learning and AI. And I think that's where the advantages can really be put into place. And as Anil mentioned, the foundation is interoperability. Without that, you cannot achieve digital transformation. So that's the foundation right there to start with. But I want to come back to his point, which I think is what will be the differentiator, is that once you accomplish that and you leverage the computing power, you can then begin to take advantage of AI and machine learning for what we call at Google automated clinical sense making. Because the challenge for primary care docs is that, again, it's too much. The demand and the data and the information, it's literally too much. And then you add genomic data, social determinants data. How do you make sense of all of this data and turn that into information that can be turned into knowledge? And it has to be done in the background in an automated fashion to support delivering insights, not generically, but really in the workflow at the right time and the right place. And I'll close just by pointing out a recent article that came out at JAMA December 9th that talks about the diagnostic process as wayfinding. And I think that's a use case and an example of how technology can really enable the primary care process and support the objectives of advanced primary care as well. And it just talks about how AI machine learning can really facilitate the diagnostic process in a way that's not possible otherwise. And again, the more data and the more semantically interoperable data that you have available, the more powerful these tools become. So, but I'll close there, but to say, and again, I work for Google, and Google is really doing this in a generic consumer fashion. You'll see if you do a Google search now, you get anticipated questions and answers. We should begin to do the same thing in terms of providing clinical care as well.
Thank you so much, Charles. Elisa, I'm looking forward to your comments, your reactions to what you've heard so far.
Yeah, thank you so much, Sarah. And before I start, I wanted to thank Primary Care Collaborative for the invitation to be part of this really terrific event, talking about a very important topic. And I also want to preface my comments by saying that while I have some titles in various organizations, including ACP, which is a partner to PCC, I'll be speaking purely on my own behalf and my own perspectives as a frontline physician taking care of patients, and also navigating the terrain of how to incorporate IT and technology interfaces in the day-to-day work of caring for patients. So I've really appreciated listening to the comments from Anil and Charles. Let me start off by reflecting on what it has been like in really becoming adjusted to this new domain of having technology in our practice. The COVID-19 pandemic has changed so many things about how we take care of patients, and in primary care in particular, it has been both a boon and also a source of a lot of challenges for primary care. Needless to say, the financial challenges of trying to operate primary care in COVID-19 has been a continuous and ongoing struggle. But what has been remarkable about being in primary care during the COVID-19 pandemic was to literally watch over a course of days, when the pandemic caused lockdowns and people really were not able to go see physicians in the office, was how quickly we were able to adapt to technologies like virtual care and telemedicine that we had been discussing and contemplating for months and years before. And when the need arose, in a matter of days, we suddenly now, through various platforms, we're taking care of our patients virtually. So that exponential trajectory of how much virtual care and technology has now entered in the interface of what we do as physicians taking care of patients has been pretty remarkable. And that has really come about because of our pandemic situation. So reflecting on some of the comments that both Anil and Charles had mentioned, I would first underscore just how important it is for data that the primary care physician is receiving to be segmented, organized, analyzed, and to not just be a data dump into the inbox of the primary care physician. Primary care is incredibly important to the health of our patients and, frankly, to the survival of our current profession of medicine. And it is foundational in terms of how we can best address longitudinal comprehensive care of our patients. But right now, the way it's set up for primary care and technology, there's an increasing number of ways that data can be transmitted to the primary care physician. But from my perspective, not necessarily a concomitant level of ways to manage that data. So while it's great to be able to get all sorts of readings about a patient's home blood pressures and all sorts of records from various other hospital facilities and healthcare institutions related to our patients in our primary care panel, it just becomes an increasing amount of volume of information. So without some analytic process, some type of a way that that data can be parsed out and organized, it becomes almost overwhelming. And we definitely don't want the move towards having more technology assisting our care of patients to then become a source of burnout. Other aspects of comments from Anil and Charles I wanted to touch upon is the importance of some type of automation. And that's where we may have some opportunity to really leverage this technology to assist our primary care physicians. Perhaps with the utilization of AI, there may be ways that AI platforms can quickly scan and look through outside records, figure out what is the vital information. There may be ways to also leverage enhanced technology communication between patients and our portals that we have accessible to patients so that information can be more seamlessly registered into the patient's charts. And I'll also add one additional feature that I don't think has been touched on yet, but the ability to communicate with our patients now in much more of a technologically advanced way has in many ways opened up opportunities to provide care to patients who may have trouble coming into the office. And that was something that we ended up doing of necessity during the height of the pandemic, but much of which can still continue. The one caution with all of this, though, is with all of this technology, we want to be thinking about who might we be leaving behind. You know, the so-called digital divide, this increase in reliance and dependence on technology, we need to make sure that all of our patients have that access. People who may be less financially advantaged may not be able to have some of the tools that some other patients will. Will that put them at a disadvantage? What about the technologies that we're offering our patients who may not be primarily English speaking? If they're limited English proficiency, are we going to provide these technology interfaces between those patients and their physicians in a way that's linguistically language accessible? And then finally, I'll end my comments by saying that despite all of the advances, we are still tied down with a lot of, for lack of a better word, analog devices. We still have fax machines that are sending us prescriptions. We still have paper charts because we don't have true interoperability between different electronic health systems. So all of these are challenges that we definitely want to look forward to tackling as we think about how we can practice advanced primary care in the age of high advanced technology. Thank you.
Thank you so much. I'd like to thank our panelists. Also, I'd like to bring our panelists back for our panel discussion. I'd also like to remind the attendees to go ahead and submit questions if you have any at this time. And once we have our panel discussion, we'll be opening it up to those questions that have been submitted. Okay. Anil, I was wondering, how is technology enabling the attributes of primary care in the shared principles, and where is it falling short?
I think the best example where it is contributing to the shared principles of primary care is really thinking through when we start looking at aggregating all this data that's coming at us from not just the local electronic health record, but also affiliate practices in a clinically integrated network and then bringing together claims data, we're beginning to see a much richer 360 view of the patient. The gaps that we typically lived with are no longer acceptable to us anymore. And so whether there are care gaps that we're now able to see are really actually not care gaps, but were simply data gaps, or if there are true care gaps, we're able to fill them with more confidence. That's one area. The other area would be simply thinking through, and I think what is working is starting to come up with, early in our careers, I'm sure we used to measure what we could, and now we're starting to do a little bit better job of measuring what matters. We're getting a little bit higher fidelity of data coming at us, and it's coming at us in relatively faster, at a faster pace where it's much more actionable. It's not perfect yet, but it's getting there. I think where the shared principles of primary care are still struggling around sort of the technology would be the experience that clinicians have, and in many cases, the experiences that patients have. Things as simple as getting prior authorization for a service that a physician is recommending. I don't think we have to talk to too many people or even ourselves to know that it's a pretty ridiculous experience. Low value work for everyone, for the physician, for the plan, and especially with lack of transparency, very frustrating for the patient and their caregivers. So I think technology has not lived up to its potential in the whole idea of getting approval for certain services that everyone agrees is necessary, and at the end of the day are often approved. I think another area where it's failed us, most of us would probably say we have a better experience booking a flight or making a reservation for a hotel or even investing our money than we do in managing our care. And so the patient portals, I think, has been, I won't say a disappointment, because I think when you're in the health tech world, every iteration is bringing us closer and closer. But I think when we experience as consumers different parts of the way technology can help, I think consumers have been let down with the state of PHRs or patient health records, whether they're tethered or not. And then the third one, and I'll let others comment, is I think the advances in digital health and digital health apps, I think for a technologist like me, it's amazing. But as a primary care doc, or at least as a former primary care doc who had a big panel, I think it's really daunting to think that there are hundreds of thousands of digital health apps out there, and what our patients must be facing on a regular basis if we're not empowered to know how to support them in their use of these apps. And to Elisa's point earlier, what in the world happens when they decide to hit the button that says send all my data to my primary care doc? How in the world are the docs going to be able to, how are we going to be able to figure out what to make sense of? So I think technology, we have a ways to go. I think, to be clear, I believe that technology has brought us pretty far along, but we got a ways to go.
Charles, do you have anything you'd like to add to that?
I think Anil stated it very well. I would just pick up on a couple of points. I think the opportunity, again, assuming you get the 360 view, that longitudinal health record, everything is really so dependent upon that. But if you're able to accomplish that, you can begin to do the automated clinical sense making in the background. And to Elisa's point, you're presenting to the doc information rather than data. And I think that's so important. I think the current systems have failed in that regard. It's just spewing data at docs, in the EHRs, et cetera. And they weren't built for providing clinical care. They were built for billing purposes. And so I think that we have to recognize we need to now move from that into the space of really aiding and assisting docs in providing care in a comprehensive fashion. And I'll also pick up on a point that Anil made. I think the other failure point is in the fragmentation of all these tools and apps, et cetera. And you've got a digital therapeutic opportunity that is being wasted in many cases because these capabilities aren't integrated and aligned and organized as an ecosystem that a doc can order and manage and get closed loop feedback around. So I think that's the challenge in front of us, the potential. But again, we have these kinds of barriers that have us still, frustrated, frankly, with technology.
So you spoke earlier, Charles, on digital transformation, which is a passion of mine, and I loved hearing those two words. But I was just curious, do you think the pandemic will help drive some of that? And if not, what would?
Yeah, absolutely. I think Elisa pointed out is that when the pandemic hit, in days we transformed, and all the things we thought were barriers before were not barriers, and we find they were really regulatory, issues rather than true barriers. And so I think that has opened the door for us to recognize that we really can leverage technology and virtual tools in a different way. And, and to the point you're alluding to, Sarah, that doesn't mean just throwing tools out there. That means true transformation, like new workflows, new models, new business models, new ways of interacting with patients that now take advantage of the new capabilities. And that means we're doing things we cannot do without the technology. When you get to that space, then you're talking about true transformation. And I think we're seeing, point solutions here and there. But again, how do we begin to bring that together for true transformation at scale?
Right. They need to work together. We can't just have thousands of apps independently operating.
Exactly.
Sarah, could
Alyssa,
I
you
yeah, thank you.
Yeah,
Thank you. I was really appreciating hearing Anil and Charles flesh out a bit more too. And prior authorizations, clearly a thorn in any physician's side, but it's also, to Charles' point, the fact that much of our data that we are receiving on the receiving side as a frontline physician is not necessarily for taking care of the patient right in front of us. A lot of it is sometimes utilized for reimbursement purposes, billing purposes. So as I think about how we can get our current level of technology and transform even better to improve our patients' health, we're here to talk about advanced primary care. Advanced primary care for the future, with exponentially increased amount of data that we're receiving, will require a team. So we want advanced primary care with physicians leading teams where there may be a clinical pharmacist that's going to pull in some of the data about medications and drug-drug interactions, where there might be a population health manager who's helping to develop rosters and be able to scour, when patients might be due for their latest hemoglobin A1C, or to help scour through some of the patient flow sheets through the portal that have blood pressure readings. So we can't continue to just data dump right into the primary care physician's box. We really need advanced primary care to expand along with the huge amount of exponentially increased data that we're getting. And that's where really thinking about the team and who on the primary care team is the right recipient of some of this data, scaling back on things that are really only needed for reimbursement. And I like to call the phenomenon of note bloat. I'm sure many of you have heard that before, but we now have great electronic health records, but we also now have notes that are probably 100 times longer than they were 20 years ago. And if that meant we were taking 100 times better care of our patients, that would be one thing, but I'm not sure that it's a directly proportional relationship. We just have a lot more data that's just getting imported for the sake of importing into something. And so being really scrupulous about the data that we're receiving, what is the end goal with that data, and who should be managing that data? Is it really physician level? Is it better left to even some of the support staff that are supporting the physician? So if we're talking about digital transformation, we also need to, in my opinion, think about transforming how we deliver primary care, where the physician is leading a team, where there's a lot of other support staff, clinical support to help manage this huge amount of data. And then my last response in listening to Anil and Charles' comments, Anil had talked about the explosion of all of these digital apps. And not only is it perhaps overwhelming to our patients, but I would imagine it also feels a little unsettling, because for every Apple Watch where you're putting in your health information, where is that information going now? It's already scary enough to have all of your information out there in the cyber domain. What about the fact now that some of this might actually be HIPAA, HIPAA type of information? And I will point out that as a member of the ACP Medical Informatics Committee, this actually had come up in discussion in some of our deliberations, and ACP put out a position paper to help codify some of the guardrails for how to navigate for patients a lot of this private health information with all of these digital apps, and how do we reconcile that? So it's a tool. A patient can check their own heart rate and realize, wow, I have a heart rate now of 150. That's probably not good. Maybe I should call my physician. But then all of their information is now in there in this whole digital stratosphere. And what about their own privacy? So these are all sort of exciting, but also uncharted territories. And I think the digital transformation needs to be paired with a transformation of how we think of delivering primary care to truly achieve advanced primary care.
Sarah,
thank you, Elisa.
I just want to have a quick comment on what Elisa was sharing, because I think it's right on. I do want to push back on one thing, not really push back, but just sort of maybe challenge us to think about it a little bit differently. I think if we add more people to the care team, for certain things, it makes perfect sense. But for other things, we need to start thinking about some of that low value work and asking ourselves, can we use robotic process automation? Can we use some AI to do the hunting and pecking for information? Can we start reimagining what the care team would look like if perhaps we had slightly more people, but had a lot more automation and a lot more other sort of corollary functionality that we somehow don't have today? I know there are some fears, legitimate fears around the use of AI, and I think the regulators, along with our primary care community, is going to force a balance between what makes sense and what doesn't make sense. None of us want to be replaced by machines, but we want to have the low value work we do replaced by machines. The other quick comment I'll make around sort of the regulatory side, I worry less about where the challenges that some of these vendors who are putting out apps might have on HIPAA, because I believe there's a pretty strong presence there. It's the ones where they're skirting around HIPAA, or they're somehow feel that they don't have to worry about HIPAA or have to worry about patient privacy, or that somehow the 30-page consent document that they put up in front of a patient is sufficient to be able to take their information and do whatever they want with it. So I do believe that there is a need for the primary care community and the clinical community in general to ask ourselves, what is our role in helping the consumers navigate what is really a complicated mess? And whether that's more regulatory language, I'm not sure about, but what we do need is some level of consistency around what is required for us to be prescribing digital apps, and then how we bring that information in. Maybe we don't bring in information at all from apps that are not certified or approved from the way that they conduct their business.
So Anil, I'm so glad you said that, because we do know that there's patient trust issues with all of this data free flowing, and some of the organizations out there, they don't really help make patients feel any more confident, do they? So I think you're right in terms of regulation. Also, I wanted to mention real quick, Patient 360. Everything you described there sounds really amazing. Is there another country or a use case of somebody who does this well?
So I was referring to something that we do where we bring in all the data. The app is called Patient 360, but there are other organizations. Even if you look at the EMR vendors, they're attempting to create these patient synopses or these patient summaries that bring in disparate data. I think the difference between purely regurgitating data that you know about a patient versus what I'm envisioning and what we as a company are striving towards is really thinking through something that Elisa said earlier. don't just show me data, tell me what the insights are. So to give you a perfect example is don't show me just the kidney function of a patient. If the kidney function combined with other information is telling me that this patient's at risk for kidney disease, then flag that to my attention and don't put something less trivial higher up than the importance of their kidney function. So it's understanding the relative nature of importance of different things, but also summarizing information in a way that it's not a black box. A clinician, given sufficient time, would have arrived at the same conclusion, but in the way that these algorithms work, we serve it up a little bit faster. But I think this whole idea of a patient 360 view, we need the traditional sources of data and we need the non-traditional. So for example, we work with Experian to bring in the consumer information about an individual so we know what might be important to them in engaging. So let me pause there, but I think it's full picture.
Great. Charles, I'm curious. Please address technology as a way to manage population health. Population health is a really big topic these days, especially for early detection of chronic conditions.
Yeah, I think that having that 360, again, let's assume that that's available and it's there. And picking up on Anil's point, as you begin to bring in more social determinants as well, you have a richer data source. Now, the value and the power of AI and machine learning is really being able to sift through all that data. And again, doing the automated clinical sense making such that you are watching for patterns. That's what's different from AI versus rules that we used in the past, where we had if-then rules. You had to know what you were looking for. With AI, it can sift through just enormous amounts of data, and you just tell it what you're looking for. So you can just say, I'm looking for a diabetic with rising risk, which looks like this. And then the AI tool will sift through all of that data and find those patterns that predict that diabetic has a rising risk. And so that's really what's different. And now you can begin to scale your surveillance of your population by having access to this data. And I think to Elisa's point, you're not inundating the PCP with things with noise. You're basically picking up only on signal that, okay, the PCP needs to know about this and address this. Or you can assign that to a team member to manage those signals as they come up, and then only have the doc managed by exception. And that's the power of the technology that we currently have available for population health management. And then you begin to get into true population health management and being able to scale analytics and algorithms at a level that's going to have an impact. And one thing I'll add as well is that the other important component is the machine learning. So this is a learning system, and so as you get more data and experience, you actually can improve your quality and the precision of your interventions over time.
Thank you. Elisa, do you have any tips for implementing remote patient monitoring, especially continuous glucose monitoring in primary care?
Yeah, thank you, Sarah. So I guess from my perspective, this may or may not be helpful enough for whoever asked that question or whoever was hoping to get an answer. We have a system in my organization where a lot of the remote data collection can be done through our portal and through the assistance of support staff, where they're able to connect, perhaps, for example, a patient's Dexcom or Libra or whatever machine that they're using, so that it feeds in to the chart. And then often that will populate in and we can take a look at those results, or in some cases the nursing staff can take a look at that. So in terms of practical tips, there has to be the right tools first on the receiving end, making sure that there's some sort of a portal connection that's encrypted that will create the privacy features needed so that that type of information can be received. And frankly, having the right team members, the support staff, to manage all of that data, because while to Anil's point, agreed, we don't want to manually populate teams to get bigger and bigger to deal with low value work. And I'm a big proponent of AI also to utilize it, particularly if it's taking a lot of data and doing data entry and just kind of getting that in there for the remote glucose monitoring, or even for remote monitoring of any other parameters like blood pressure, et cetera. There really needs to be the right interface, the right electronic interface for the patients, the patient portal, enough education to let them know how to navigate getting that information in. So not sure if that's practical enough, but I think that first off, the hardware has to be right. There has to be the right amount of support staff clinically, and also a workflow to know how to address that information when it is received. And with respect to just reflecting on a couple of the points already that Anil and Charles had made before, there is a lot of excitement in just listening to Anil and Charles talk about the machine learning and how it can help in clinical decision making. And I am definitely not a Luddite, and I'm excited about those possibilities. But I will say that the real world experience right now is the fact that we still have to grapple with fax machines that are spewing hard copy paper fax requests for prescriptions. So it's like the strange dichotomy where we're thinking at the next level of how can we help our physicians and clinicians with diagnoses and management by training AI and using machine learning, but then we have to go to a fax machine to still pull it off and then still somehow digitize that to get the prescription sent. So I would say my last takeaway comment is, how do we elevate the baseline level of technology everywhere so that the analog is no longer needed, as well as going to the next level with respect to digital transformation? And so hopefully that was the answer that was hopefully helpful for that particular question.
I want to let our panelists know that we have lots of interesting questions that have been submitted. So, and we're down to about 6 or 7 minutes. So I'm hoping maybe we can keep our responses kind of quick on these last questions. How important is it for primary care initiatives to emerge from local stakeholders versus regional national efforts? Or can a national solution be made to fit every community? Who wants to take a quick time to respond to that one?
I'll take an initial stab. I think both ways work. I think there are some tools and technologies and approaches that need to be done at a national level to demonstrate that there are commonalities in play, but we all know healthcare is local. So for some things, we need to start locally and meet somewhere in the middle. I think it's critical, going back to the comment that Elisa made earlier about the fax machine, it's critical to understand that there are some archaic laws that are at the state level or at the regional level that kind of prevent us as an entire nation to be moving forward in a very predictable manner. So going back to your question, Sarah, about some of these initiatives, I think we have to do it both ways and demonstrate to our regulators, demonstrate to the lawmakers, demonstrate to ourselves that some of these things can be scaled, can work, and that some of these local variations need to be in the history books and not in our laws.
Yeah, I'll follow up, Sarah, to Anil's comment and agree wholeheartedly. It can't be one or the other. It really needs to be both. The local is what often is ultimately how things get executed. National could be more of the policy and the direction and the directive, but ultimately what happens at the local ground level in offices, in examining rooms. So we really need at the local level to make sure that whatever is happening, either policy-wise or as initiatives or guidelines or guidance at the national, federal level, can translate in a way to be implemented at the local level. So we really need the partnership to happen.
Charles, I think I got the next one for you. A couple of weeks ago, Facebook and Microsoft announced that they will be focusing on building metaverse, where people can meet each other virtually on a more interactive way. Some people believe those announcements were overhyped. I am curious, what is your opinion on this upcoming technology? And do you think this new version of virtual interaction will change/play an important role in the future of our telehealth? It's an interesting question.
Yeah, it's just, and I don't want to appear like a Luddite either, but, but I frankly, I do think they're a bit overhyped at this point. However, I will point out that there are some studies and some evidence that virtual reality is helpful in healthcare in certain instances, and pain management, for example. See some evidence there, in cancer patients. So I think that there's a place, but it's one of those things where you really have to match the solution to the problem and not have a solution in search of a problem.
Okay. Here's the next question. Can you talk about the effort to short circuit the problems between the major electronic patient record companies in terms of the interoperability stalemate? That word is painful, interoperability, in many ways.
Yeah, I think this is Anil. I'll take a quick stab at it. I think the key thing is to keep putting pressure on protecting the consumers who want access to the information, and making the vendors who have data make that available in easy to use, low barrier, friction free, whatever words you want to use, way of getting it out with semantic understanding of how the data got in, and then when it comes out, maintaining some of that provenance of the data. It is critical that that pressure be maintained. Otherwise, I think we're going to have the haves and have-nots, and it's going to be a critical piece. Interoperability comes from knowing how the data got in, who put the data in, and some of that information is lost today when we talk about information sharing.
I'll jump in with
talk about that. Elisa, I have a question for you.
Oh, you do?
I have a question for you that's kind of related, and so maybe you can tie it together since we're running out of time. People we are leaving behind also include independent primary care physicians who are not financially able to invest in technology. What can we do about not leaving this group behind?
First and foremost, we need to keep hearing their voices, and I know ACP particularly has been very, very strong of an advocate for the independent primary care physician, recognizing that a lot of this digital transformation has a cost, and is that cost able to be supported by independent practices? And if not, what can we do to find ways that we can still offer similar technologies but have it be more affordable? We have to support the independent physicians, because for many parts of the country, they're the only ones really that are able to provide care to patients, particularly in rural areas or areas that don't have a major urban hub. So I think the key there is making sure the voice of independent primary practices are always at the table with any of these decisions, and any decision to try to regulate digital transformation technologies, and recognizing that they're going to have a different way to manage the expenses. And then to follow up on Anil's response to your question, Sarah, about the interoperability, I'll just keep it at a really basic level. I have some hospital systems where I can't access their records at all because they are on a different electronic medical record platform. And the only way I can see their records for a patient that I take care of is we have to get the paper chart. That's just unacceptable. And we need to keep the pressure on, as Anil said, and recognize this can't be about financial interests and commercial priority about who's going to own what. They're creating redundancy in care, potentially safety issues if we don't receive the records in a timely way because we can't communicate electronically because some sort of a financial block. We may also miss things. So it's patient safety, and it's also obstructing care. Thanks.
Hey, I'd really like to take this opportunity to thank our panelists. They were amazing today. Dr. Jain, Dr. DeShazer, Dr. Choi, amazing. I'm so glad I got to work with you guys today. I'd also like to thank all of our attendees and remind them that access to the slides, the recording, and additional resources are available on thepcc.org, and that the recording of the webinar will be posted within 24 hours. Thank you, everyone.
Thank you.
Thank you.
Bye.